But the most common area of bleeding will be intra-articular. And those more common are the knee and the ankle. All right? Of course, if I have a bleed at the level of the knee or my ankle or anywhere in the leg, in the hip, if there's no contain of that bleeding, I'm going to tell you the treatment in a second. What do you think could happen? Well, ischemia of the soft tissue and necrosis up to the point that the tension and the pressure of the muscle is so increased that the patients can go into compartments, right? So what are the clinical manifestations of patients with hemophilia? Well, bleeding. Bleeding where? Soft tissue is the most common. And most commonly, as I said, intra-articular joints. And the name for spontaneous bleeding at the level of the knee, you need to know that name is called hamartosis. Okay? So what else? Well, they can have petechias, they can have hematomas anywhere, purpuras, even though their problem is not related to bleeding, right? So whenever there's a containt of blood that increases pressure, not only the muscle, the subcutaneous tissue could be affected, but every single area surrounding the blood at high pressure could also be affected, such as nerves and tendons. What are the areas that the patient bleed? Well, of course, they can have microscopic or microscopic hematuria, so evident or through microscopic. And they can have, as I previously said, intracranial bleeds. Even though it's not the most common, unless the patient, of course, has a traumatic brain injury or motor vehicle accident, where the patient suffers a fall and hits the head, right? Laboratories. If the problem of this patient is related to the coagulation cascade affecting factor 8, 9, or 11, hemophilia A, B, or C, what controls that? What controls those factors? Will be PTT only. So PT will be normal, INR will be normal, platelets are normal, and the patient shouldn't have anemia unless there's an acute bleed. Do you understand? You need to know the laboratory. In addition to that, what else do you think you're going to be searching for? The factors. So basically, you order a blood test and see the amount or quantity of the factors to see what factors they have deficient. So, of course, in hemophilia A, they're going to have factor A deficiency, B, 9, and C, 11. But that's easy to understand. So, in clinical practice and board examination, what they want to know is that you are able to differentiate between other hematological disorders that hemophilia only has PTT affected. All right? Follow. So how are we treating these patients? Well, it makes sense on the second line that says avoid any type of antiplatelets. No, because the platelets are affected. It's because the only source of coagulation that you have on that particular patient are the platelets. If you remember, when the patient suffers any type of tissue injury, who migrates first to the area of inflammation or infection besides the leukocytes? The platelets to produce the clot. Imagine that patient is bleeding due to deficiency of coagulation factors, and now you also inhibit platelet aggregation, so the patients will bleed more. So try to avoid at all costs until the patient, I'm talking about acute bleeding episodes. I am not saying that a patient with hemophilia, it now goes into coronary artery disease, acute coronary syndrome, they're not going to give aspirin and platelets or Brilinta. I am saying that you have to avoid this at all costs when the patients are acutely bleeding. All right? Now, let me tell you what is cryoprecipitate and what is FFP, so you will be able to differentiate one from the other and what to give when. Okay? So besides cryoprecipitate having factor 8 and 13, as you can see, in essence, the only one that I have in high quantity is fibrinogen and factor 8. So, for example, you know, or you will know in a second, that disseminated intravascular coagulation, the main factor that is depleted is fibrinogen. So cryoprecipitate will work beautifully for patients that have DIC because they have high quantities of fibrinogen as well as factor 8.
They give it a lot in training.
It's very safe. And in addition to that, thank you for telling me that, cryoprecipitate does not contribute to high volume. So if at any point your patient is in volume overload state, such as a CHF patient or a pregnant patient that physiologically is in volume overload, or a patient that has, for example, cirrhosis of the liver, but is not related to vitamin K deficiency, okay? The patient is bleeding because it's a hemophilic patient that decided to drink and now has liver cirrhosis, or a patient with cirrhosis of the liver that had right-sided heart failure and now has liver cirrhosis due to that. Those patients are in volume overload, aren't they? By nature, due to decrease of heart pressure. So if you now have to stop a bleeding episode due to factor 8 deficiency in a hemophilic patient that is liver cirrhotic and volume overload, I'd rather give cryoprecipitate than FFP, because even though FFP also has factor 8, it will contribute with a large amount of volume. Okay? So FFP has all the coagulation factors that you can imagine, except platelets. So if you need to transfuse platelets at any point, FFP is not going to do any type of platelets to resolve that. And as I said here, it's a volume expander. So patients bleeding hypotensive, and I understand that you will transfuse factor red blood cells because that patient at that moment will be in an acute blood loss anemia, but why not as well give the patient FFP, because not only you are giving coagulation factors to the patient, but you're also contributing to volume to increase the blood pressure. Okay? All right? So the rest is not as significant because is platelet a significant factor that is decreased in hemophilia? No. Platelets are not affected in hemophilia. So there's no need to transfuse platelets to the patient. Okay? This is just for your knowledge that I put from the past, that factor red blood cell, when you give a factor red blood cell to the patient, the average increase of hemoglobin is 1-to-1. Sometimes depending on the size of the factor red blood cell, you can increase 2 grams per deciliter of the hemoglobin. But if you, for example, have a patient with 6.8 and you give 1 unit of factor red blood cells, you expect the hemoglobin to go at least 7.8. So in case you didn't know how much to give, 1 or 2 factor red blood cells. Okay? Any questions so far? No questions?
What is how many units you said for each type of red blood cell?
1 to 2. No more than that.
How much would it go?
So if you now, for example, have a patient with a hemoglobin of 6.8 and you transfuse 1 unit, and then after that, when you do the H&H repeat, the hemoglobin comes up to 9 to begin with. Exactly. It's impossible because to begin with, that patient shouldn't have 6.8. Most likely it was a laboratory error. You understand? Okay. So now the problem is that even though patients with hemophilia will constantly bleed, you do remember that whenever a patient is through a bleeding episode, through any type of hemolytic episode, even though these particular patients are not breaking down red blood cells or they're not breaking down platelets, any major bleeding episode in your body is captured by the liver and by the spleen. One of the major functions of the spleen, if you remember pathophysiology, is to, number one, immune system. Number two, getting rid of any type of hematopoietic cells that are dead, cremated, or malformed. Okay? So therefore, patients are at risk of having an activation of the spleen at a point that they get splenomegaly. And when the spleen grows and grows and grows and becomes active, produces ischemia. So basically, it's like the heart. Imagine the heart working and working and working through a major chronic hypertensive episode. Don't you remember that the heart goes through remodeling, left ventricular hypertrophy and remodeling? And then eventually, what happens? Well, the systolic pressure is impeded because it's like a floppy heart, right? Same thing happens at the level of the spleen. The spleen is recognizing that there's a major hemolytic episode and produces engorgement to try to eliminate all the cells that are cremated, okay, or malformed, because I'll tell you now in a second about the bone marrow. And that hyperactivity of the spleen produces ischemia of the spleen and necrosis of the spleen. So when the spleen goes through necrosis, one of the major functions of the spleen will not happen. Getting rid of those malformed or cremated cells by the hematopoietic system. And therefore, what do you think would happen? They will all clump and they can produce thrombosis as well. Even though it's not the significance of this disease, it's a complication of this disease. Another function of the spleen is to be able to protect patients against encapsulated microorganisms such as meningococcemia. Patients that have streptococci pneumonia or Haemophilus influenza. So every single patient that goes through hypersplenismo, meaning increased spleen and increased activity, and a splenic infarction, which is called alpha-splenia, patients must be vaccinated. So they're high risk, in other words, to major infections, and their immune system gets depleted. Going through major complications of viral diseases, meaning that they're highly exposed not only to these three types of bacteria, streptococci pneumonia, and having death due to pneumonic episodes, Haemophilus influenza, and they're also at risk of meningococcemia and death. But in addition to that, they're highly exposed due to the decreased immune system that is compromised, and in addition to that, get viral diseases such as hepatitis, varicella, mumps, even though they have been vaccinated for years, it doesn't really matter, and also parvovirus. But going backwards, even though hemophilia is a completely congenital condition, you would see that many of the hematological disorders that I will discuss in a second are associated as a trigger factor viral disease. So these patients, if they have hepatitis, they can have, for example, ITP or TTP. If they have parvovirus or hepatitis or HIV, they can develop these hematological disorders. So what I'm trying to tell you as well, even though these are complications for hemophilia, these are etiological factors for many other hematological disorders that we will study today. And you must do viral serology for these patients to be able to root out the cause of the disease and treat appropriately. So again, it makes sense that if you have hemophilia A and you're missing factor 8, the best treatment is to provide factor 8, right? If you have factor 9 deficiency, to provide factor 9, and so on for C, factor 11. But what else can we do meanwhile? Because these factors are very expensive, and sometimes they're not available right away in the hospital. You can contain the bleeding, the acute bleeding episodes with, remember, for factor 8, provide a precipitate. And for the rest of the factors, 9 and 11, you will be given a. But if you get a question of the ideal treatment or the most definitive treatment, would be actually to provide a factor for the patient if it's available. Okay? Correct. Okay?
I have a question.
Yes.
What if the patient's a transplant patient? If they already have an organ and we don't want to reject, you have to give them blood products, and that's a risk.
Yeah, I know that you have to screen very properly for antibodies, but you're gonna let the patient bleed, you said, while you're waiting for the factor to come?
You try to treat, right, by like medication, the Benadryl, something for
Exactly, all prednisone. All right, so this is just no more than a review of the population cascade in case you don't remember. Remember that the main trigger, the stimuli for the population cascade to be activated is inflammation. Anything that activates tissue factor that produces a major inflammatory response, and it could be anything. That could be from a viral condition, bacterial condition, an autoimmune condition. That could be trauma, burns. That could be motor vehicle accident. That could be sepsis. Any trigger will activate tissue factor, and the population cascade will get activated. Yes.
How do you know how much of it needs to cure? Like, is there a formula or something to cure?
This normally the same as factor blood cells. If, for example, platelets. In platelets, for example, if you give 1 unit of platelets for one single donor, it will give you an increase of at least 10,000 units of platelets increase. Okay. For FFP, if you give 1 unit of FFP, the factors will increase by at least 5%. Okay? But in that particular patient, if you give an FFP, you have to evaluate clinical findings on the patient to see if the patient continues to bleed. We had a patient, let me tell you a patient that we had this weekend on Kennewick Regional. This is a patient that had occlusion of the left MCA cerebral, and he developed a stroke 3 weeks ago. And he underwent, you know that ischemic strokes are from bodies, right? And so sometimes you're able to see by CTA or perfusion, CT perfusion, you're able to see the occlusion, and then basically you program the patient to go into a interventional radiologist and to have the patient come back to me or to inject TPA at the area, right? Well, the patient was identified with an acute thrombosis, and they took the patient to the surgical room, basically for procedure. They did a thrombectomy and they put a stent on the vessel, on the left MCA. Patient recovered, only mild deficit on the left side, and patient went home. Patient developed acute stroke symptoms again, and the patient comes into the ER. Of course, the major concern is the occlusion of the vessel again, or the stent is placed, and they take the patient into the interventional radiology room again, and exactly they saw that the stent was not displaced, but he develops another clot. So they inject TPA. They could not give a systemic TPA because the patient was already on an extreme. Okay, so that's one absolute contraindication. So, but after they injected TPA intra-arterial, nothing to do, okay, because it's only intra-arterial. For some reason, the patient started bleeding. through the upper GI. It was coffee ground bleeding, no major problem. It wasn't affecting the hemoglobin. So patient was in the ICU, intubated, sedated, waiting for GI to come the next day and do an EKG. But while we had the patient in the ICU, not only the patient was having coffee ground MSE, he started having hepatitis. Now we had a major problem. The interventional radiologist was calling us all the time saying you cannot stop aspirin and Brilinta on the patient because the patient already suffered a closure of the vessel twice. So if you discontinue aspirin and Brilinta on the patient's going to die and have more consequences and more disability than if the patient continues to live. So we had this major deal of, that was a beautiful case. We had this major deal about giving aspirin and Brilinta to the patient, but at the same time containing the bleeding, and how? What do you think we did?
Protonic strip.
We couldn't, no, heparin no, heparin is
First,
contrary.
drip.
Okay, protonic drip,
Sandostatin.
sandostatin to constrict, even though this is 668, sandostatin to constrict the vessel, even though we weren't able to know exactly that the patient had AV malformation. Sandostatin, by the way, is only for esophageal viruses, but has the beauty of constricting the GI, the plaque circulation. So we did that, sandostatin, protonic strip. What about the bleeding?
You give transfusion.
Packed red blood cells. Why not give cryoprecipitate or FFP?
You're all going off there, you're increase the pressure, you're overloading.
So they're gonna put it
No,
Well,
because I'm giving coagulation factors. And if I give coagulation factors to the patient, I will clot the vessel.
but why did you say Brilinta? Brilinta has no antidote.
No, honey,
What? No,
it doesn't matter.
you cannot.
We could not stop the dual antiplatelet therapy of the patient because he was going to have a closure.
Right, but my point is that that it has no antidote, but the heparin does. 'Cause, like, I've spoken to our cardiologist in regards to this, and he's like, rather than having a patient.
But we couldn't put the patient on anticoagulant because he already received PPA. It's arterial.
So it was more the.
And the INR was 1.5, and we couldn't reverse it. Because if we reverse it, he was gonna closure the vessel. Alright? So that was a beautiful case about that. So his major trigger of bleeding here, we don't know exactly, most likely because he was already on an extra. Maybe he was already having some vessels friability, and maybe through the acute episode of closure of the vein, it will produce the curling ulcer, and when, I don't know, patient started bleeding GI that had nothing to do with his event. Maybe he was gonna have the GI bleed already on an extra, but we capture it at that time during hospitalization.
Maybe he had a undiagnosed bleeding.
As I said, maybe because it was too soon for the patients to develop stress ulcers. You know, he went home on an extra. He came back right after 3 or 4 days later with this stroke episode at hand. Okay, so I do truly believe that he was going to bleed GI twice anyways during those days, but he bled.
Will come back in, the low hemoglobin, super complicated.
No, I was transfusing, and the hemoglobin fat. It wouldn't go up. Well, finally, we were able to put the patient into a bleeding scan, and we saw a vessel, an active vessel bleeding. So they came to the bedside and did an embolectomy. And he continued. All right? So remember that any type of insult not only activates tissue factor, but also activates platelets. And I need to refresh you as well in the sense of platelets, even though the platelets migrate to the area of inflammation or infection or trauma or endothelial injury, you need 2 factors for the platelets to adhere. Otherwise, the platelets can be in high amounts in plasma and they don't do any work whatsoever if those 2 factors are not present. And those 2 factors you have a good memory, is bone Walram factor and glycoprotein 2B3A. And if they are any of those or both are deficient, the platelets can aggregate and the patient is bleed. Okay? 2B3A.
I had a patient that was deficient in one milligram factor and had to go do a endoscopy and was bleeding, and we kept having to give him like factor 8, like transfusion,
You know why?
before and after the procedure, like almost every 12 hours, because he just would just bleed.
Even though bone Walram factor is not a treatment for hemophilia, bone Walram factor will accelerate the production of factor 8.
So there's
It's an adjuvant of
there's no
treatment.
factor 8.
It's an adjuvant of treatment. You would see in another condition that we'll study about ITP that desmopressin, the one that you learn or will learn in diabetes insipidus as treatment, desmopressin will accelerate the production or stimulate the production of bone Walram factor. So desmopressin is a treatment for hematological conditions, and we'll see that in a second. So again, going back to your coagulation cascade, you need an insult for the coagulation cascade to be activated, otherwise it remains dormant. Okay? So you have the intrinsic cascade that after tissue factor is activated, it converts from 7 to 7 activator. From 7 activator goes to factor 8, factor 9, factor 10, factor 11, and 13, and then it goes from plasminogen to plasmid, fibrinogen to fibrin. Okay? Remember that so far? Good. This is another representation. Again, if you have any insult, maybe trauma, you have tissue factor, even though it is here, but it's actually the first, which is factor 2. Tissue factor being activated, activation of factor 7 to factor 7A, from 10 to 10A, but before that, intrinsic cascade is activated, then you get conversion of factor 8 to activator, factor 9 to activator, factor 10 to activator, 11, 12, and plasminogen to plasmid and fibrinogen to fibrin. Okay? I'm not going to ask you like that. This is pathophysiology. Okay? So you here you have the entire cascade. Okay? So basically you need a stable fibrin formation at the end of the cascade to be able to form the plaque. And we will discuss again the pathophysiology of disseminated intravascular coagulation. Remember that what happened here is that the coagulation cascade is activated in such a vicious cycle that yes, the coagulation factors get accelerated, but there's a major consumption of fibrinogen at the end, producing low levels of fibrinogen, but also high levels of fibrin degradation products, which is your D-dimer. Okay? This is just that. Another one, just to represent. Here is just to tell you that the most common anticoagulant that triggers the or treat the coagulation cascade at the level of the intrinsic arm is coumadin or warfarin, and you can measure the INR. And the most common anticoagulant that basically affects the extrinsic arm of the coagulation cascade is heparin. Okay. Now, we finished hemophilia. Now let's talk about vitamin K deficiency. What are your sources of vitamin K? Well, first of all, vitamin K is formed by the activation of bacterial flora of the intestine. So if you have a sterile intestine, such as the newborn, You need to give them vitamin K because they're not able to respond to the bacterial flora of the intestine yet because they haven't had the first feed. As soon as they have the first feed and the first meconium is formed, then they're able to produce by themselves vitamin K. Otherwise, they can't. And at the first day of life, or the first week of life, they're very high likelihood or a high risk to develop vitamin K deficiency and bleeding. Okay? So you need your normal intestinal flora. So what do you think happened for patients that are in high dosage of antibiotic or prolonged use of antibiotic that you affect intestinal flora? So these critically ill patients can have vitamin K deficiency and have bleeding. So have that in mind. In addition to that, liver. So if you have any type of disease process that is affecting the liver, like hepatocellular carcinoma, hepatitis B or C, most likely, patients that have any type of biliary obstruction, liver cirrhosis, or even patients with malabsorption. Here, the case is not the liver, but the actual intestine by itself. What about patients with autoimmune conditions, as I previously stated, with Crohn's disease or ulcerative colitis? So anytime the intestinal flora, or the absorption of nutrients at the level of the intestine, producing ischemic changes at the level of the intestine, or affecting the liver, not only will affect coagulation cascade with coagulation factors, but also vitamin K production, and the patients can bleed. So again, one example, besides those that we have on the board, what about again, right-sided heart failure? That you have hepatic congestion and hepatic failure. That could be as well another etiology related to vitamin K deficiency. Vitamin K, as I previously stated in this slide, is mandated by the intrinsic cascade. So in the intrinsic cascade, you measure PT and INR. INR, no PTT. So as I emphasized in hemophilia, only PTT is affected. In vitamin K deficiency, only PT and INR are affected. So vitamin K, as I previously stated, the intrinsic cascade is necessary to the production of factor 2, factor 7, 9, and 10. Okay? So patients, the majority would have PT and INR affected, but don't say that what I have explained is wrong or your book is wrong. You will read in some guidelines that because vitamin K is necessary for the formation of some coagulation factors that are present in the extrinsic cascade, such as factor 7, factor 9, and 10, these patients can also have a slight prolonged PTT. But the major laboratory report that is affected is due to intrinsic cascade, elevation of PT and INR. Okay? The rest is completely normal. So here you have the causes again. So what about if I now have a patient with atrial fibrillation and the patient is on Coumadin and the INR is 5? What's the first question that you have to ask? Is the patient bleeding? Is the patient bleeding? What will you do to that patient if the patient is not bleeding?
Just hold.
You hold or reduce the dose. Both are appropriate. You hold and reduce the dose, but you never give an antidote because the patient is not bleeding. Do you understand? So you hold the dose or decrease the dose. Most of the time, what we're doing clinical practice is that we hold the dose. The next stage, the INR is back to therapeutic levels, which you know that the therapeutic levels is 2 to 3, right? If it's back to therapeutic levels, then I will start with half of the dose, right? You have to decrease the dose. What about if the patient is bleeding? You have to reverse it. Well, actually, Depending on the case, right? Because look at the case that I just presented to you.
Yeah, it is, the benefits of supplement
Exactly.
formulation is not.
Sometimes it's better just to provide the factors because you know already that vitamin K is necessary for factor 2, factor 7, factor 9, and factor 10. So why not give that to the patient instead of giving the vitamin K? Do you understand? Yes or no? Okay. So the most relevant treatment for a patient that have vitamin K deficiency is to give the vitamin K. But you also have to look at other factors that a patient will have. Okay? This is a patient coming to you with Crohn's disease. Patient is having diarrhea, bloody, full of mucus. Patient starts bleeding massively through the rectum, having hematochezia. You measure the CBC, the hemoglobin is 9. The PT is 22, and the INR is 4.6. PGT is 20. What will you do? Or tell me what is the most relevant diagnosis for this patient? First, it has a risk factor that is interfering with intestinal absorption, right? And you know that with the intestine, vitamin K is absorbed. So therefore, the most likely diagnosis for this patient is vitamin K deficiency, and the most common treatment for this patient would be giving the vitamin K. I understand again that in clinical practice, we can give FFP to this patient because we are giving to the patient factor 2, 7, 9, and 10, which are deficient, that are mediated for vitamin K. But if we have the vitamin K available, the first initial treatment for this patient will be to give the vitamin K. Okay? So, what happened again if you have a INR supratherapeutic because it's 5, but the patient is not bleeding, so it is okay to either decrease or omit a dose. Next day, you have therapeutic levels, you restart at a low dose. If the level is not therapeutic, you will continue to hold, right? And observe the patient for any type of bleeding episode. If the INR is 5 to 9 and the patient is not bleeding, the high risk for this patient to bleed when the INR is 5 to 9 is really high. So as soon as the INR goes over 5, even if the patient is not bleeding and the patient has no contraindication for reversal of the coumadin, then you have to give the vitamin K.
When looking at therapeutic levels of the INR, are we considering, I know sometimes we consider whether that we have to route or not. Is it just one for everybody? Doesn't matter if they have mechanical valve?
The mechanical valve is 3.5. Okay? Greater than 5, you have to give vitamin K unless it's contraindicated. And of course, if the patient is bleeding, not only vitamin K will be given, but what else can you give to the patient? The most reliable blood product that you will give to the patient besides factors of cells if the hemoglobins are low would be in this case FFP. Why? Because Cryer only has what? ACE, 13, and Fabrinol. So if you give me Cryer, it's not going to do anything. So that massive amount of, let me give everything that you see in clinical practice, Cryo, FFP, platelets, packed red blood cells, you're basically shooting to the dark. You need to know what they have.
They don't know.
You don't know what.
Let me go back.
Everything just in case.
See, this is only when they're in the hospital. Because I used to work in the wedding clinic and recently, and sometimes even it's like I've seen it 5 and 6 and all the cardiologists they were like, no, stop it 1-2 days, but do not give it because they have
Exactly.
prosthetics and stuff like that.
Exactly. If you have a high likelihood for thrombosis, why to reverse it? If the patient is going to have, patient had a recent stroke. Right. Now the patient, we see it all the time. Patients with recent stroke, they can have an upper GI bleed or lower GI bleed, right? Due to this ischemic episode, they go through curling ulcers or stress ulcers, and they develop gastritis or bleeding due to that. If you have an INR in this particular patient of greater than 6, and now the patient is bleeding, of course you're going to reverse, right? Because you're not going to let the patient die due to hematemesis. But if you have a patient with ischemic stroke, and imagine that the patient also has Crohn's disease, and they have an activation of the Crohn's disease, and now the patient starts having diarrhea with a lot of mucus and abdominal pain, and you check your coagulation factors, and you see the PT and INR elevated, the patient is not bleeding, what would you reverse it? Because this patient just recently had an ischemic stroke, and they can thrombose again. Do you understand?
Yeah. Do you always, when you resume
But that
therapy,
is clinical practice. Guideline, either that you have vitamin K antagonist, which is Coumadin, or you have an INR elevated more than 6 on a patient that has risk factor for vitamin K deficiency, you must reverse. Because this patient has a very high risk for bleeding, even if they're not bleeding acute. Okay?
do you always reduce the dose once you start therapy, or like so it's always gonna start half dose or whatever previously on?
Well, for example, you were in 7.5 already of Coumadin. I would start at 5.
Okay.
If you start at 7.5, you don't know exactly what factors the patients would have to have that half-life increase at that point. If you continue with a 7.5, most likely the next stage might be the same thing. And then you're going to be happy to 1.5. All right? So this is a patient, 50-year-old male with status post MI. 2 days ago, he had a PTCA stent in the step-down unit of cardiac bedside and calls, still because he's concerned regarding to some new development of his heart. He's hypotensive, tachycardic, blood oozing from his right groin, where they access for his angiogram. She also notes that there's blood in the quality and seems to be increasing. There's another bleeding from the puncture site on his arms that the patient was previously using for phlebotomy. So far, this is a patient that had a main artery access, and now the patient is bleeding through the site. But not only that, the patient is having another bleed through another orifice, another organ, which is hematuria. Okay? So tell me what the laboratory results you're going to order for this patient. CBC first to see the patient, 1, hemoglobin, platelets, you're going to look for the platelets, right? You're going to do PT, you're going to do PTT, INR, and fibrinogen. Okay? If you're suspecting any type of disseminated intravascular coagulation that this patient has. Why do I think this patient has disseminated intravascular coagulation? Because it's bleeding through more than 2 orifices after a major insult. So you already answered this. Why not hemophilia? Or what factor in the laboratory would you have to look to diagnose a patient with hemophilia? PTT. What factor would you look to see if this patient has any possibility of vitamin K deficiency? PT and INR. So now we'll go through the factors that affect disseminated intravascular coagulation. So the same way that we said that there's an insult to the body, there could be any disease process, including sepsis or trauma, motor vehicle accident, burns, any type of infection. There is a tissue damage. Endothelial injury will activate the platelets. Platelets will migrate to the area of damage. But complement cascade will also be activated. And as soon as the platelets get activated and aggregate, that will activate tissue factor. That the tissue factor is factor 2 for the coagulation cascade. And you have the intrinsic and the extrinsic arm to be activated. So again, you have tissue damage, After the tissue is damaged, inflammatory cascade, complement cascade, and the clotting cascade is activated. The problem here is that at the end of the activation cascade, what do you have as a byproduct of that metabolism? Remember, plasminogen to plasmid, fibrinogen to fibrin. So the end result is a meshwork of fibrin to produce a clot. So if the insult hasn't been recognized or eliminated, such as, for example, the patient has pancreatitis or a UTI and the patient continues to have an inflammatory response, that coagulation cascade continues to be activated. And there's more and more and more production of fibrins. So therefore, there's more and more productions of thrombi. And that's the reason why here it says microvascular thrombi. That's the baseline of the patients having disseminated intravascular coagulation. It's not bleeding, it's a thrombi event. Then, because in our body, we always try to be in balance, we do have natural anticoagulants in our body, right? Protein C, protein S, factor V lady, glucose anticoagulant, antithrombin 3, that are perceiving that there's so much thrombi events that they need to start lysing it. So they start producing fibrinolysis and start to break down the excess of fibrin. And that's the reason why you see in a laboratory report D-dimer, which is no more than an interpretation of this fibrin degradation products produced by the fibrinolytic action of our natural anticoagulants. Activation of protein C, protein S, factor V lady, glucose anticoagulant to be able to eliminate the excess of fibrin. Okay? And if I do that, if I clot and I try to eliminate the excess of clot, then I bleed, then it produces a major vicious cycle. Okay?
What were the factors that you mentioned that were maintaining stable amount of coagulation factors?
Normally, you and me, all of us, we have natural anticoagulants that when we have any activation of the thrombi events, the coagulation cascade, those factors are dormant, and as soon as the coagulation cascade is activated by any type of insult, those factors get activated as well to prevent excess of thrombi. Those are protein C, protein S, glucose anticoagulant, factor V lady, ligand, antithrombin 3. Yeah. Okay, so if I clot, and those factors fibrinolyze, you have a meshwork of clotting and another action of bleeding. And that's exactly what's happening in disseminated intravascular coagulation. So the clotting factors getting activated will be interpreted in the laboratory report as an elevation of your PT, because both branches are activated. PT, elevation of INR, elevation of PTT. What about the consumption of platelets? Isn't platelet activation the first initial factor? So those platelets also will be consumed, and therefore the patient with disseminated intravascular coagulation will have thrombocytopenia. What about fibrinogen that is produced at the end? Well, it is produced, but it's broken down. It is produced, but it's broken down. So the fibrin at the end gets depleted. So the patients would have low fibrinogen. But the excess of elimination of the fibrin will give you fibrin degradation products. And that is your D-dimer. So in other words, the laboratory results for disseminated intravascular coagulation will be low platelets, elevation of PT, elevation of INR, elevation of PTT, elevation of D-dimer, but it must be present low fibrinogen. If you, on one of your patients, measure your PTT, PT, INR, platelets, and the fibrinogen is high or normal, you have already ruled out disseminated intravascular coagulation. So in other words, fibrinogen must be low. All right? So this is exactly what I just explained. You have any type of insult, activation of the coagulation cascade, the end byproduct is forming fibrin for the quad. So therefore, the patients at the beginning will have thrombotic events. Then your natural anticoagulants are in charge of breaking down that fibrin. So therefore, fibrin degradation products will be formed and fibrin will be exhausted at the end. There's no more production, there's only elimination. And fibrin will be low and the patient will start bleeding. What are the triggers for this? Anything, any insult, but sepsis is number one. Trauma, any type of thrombotic event, malignancies. You will see this a lot on patients with oncological emergencies. That will be my next presentation next week. Any blood contained in your body, such as a hematoma, anywhere in your body, any deposition of tissue, any deposition of blood can trigger the coagulation cascade to be exhausted and produce DIC. So if you have a hematoma intraperitoneal, retroperitoneal, or in your pelvis, or even a major hematoma subcutaneously, any after surgical procedure that a patient will develop a hematoma, not only will have to follow up on the increasing of the hematoma and the complications of that amount of blood accumulating, producing ischemia to the soft tissue, but in addition to that, any blood or byproduct of the hematopoietic system accumulated in your body can trigger the coagulation cascade. Any residual tissue, if the patient now delivers or has an abortion and there is residual fetal tissue or placenta, that can trigger the coagulation cascade, okay, and produce disseminated intravascular coagulation. Any vascular disorder, major vascular disorders, such as henotyl purpura that will not recover, any major insult to the tissue, such as being bitten by a snake, or any major allergic reaction or transplant or rejection, that's an insult for the body. The most common, which is not here, is sepsis associated with from UTI to pancreatitis. So if you look at the laboratory results for the disseminated intravascular coagulation, the hemoglobin will be low. Why? Because the patient is bleeding, right? Hematocrit, of course, is low. This is going to be which type of anemia? Acute colonoscopy is normal chronic. The platelets are low. Why? Because what started the whole cascade event was activation of platelets aggregating to the area, and then tissue factor, which is factor 2 of the coagulation cascade. But your PT is accelerated, which is elevated. Your PGT is also prolonged, but your fibrinogen has to be low, otherwise you do not have DIC. And your fibrin degradation products, which is also the D-dimer, is elevated.
This is only for me.
Now, where else D-dimer elevated? Actually, any insult to the body.
Anything.
Now, you come to the, if I now come to the ER with an abdominal pain and the only thing that I have is urinary tract infection, if it's not affecting the structures of the kidney, which is only functional, it's non-complicated, most likely I don't have my D-dimer elevated, right? Unless I'm septic. But if I'm septic from the UTI and or having a structural damage to the nephron or the pelvis, I can have D-dimer elevated. So I see random, like discriminated ordering D-dimer in the ER. If the D-dimer is elevated, now you have to proceed and look for the thrombotic event. At least, stop of the lower extremities, CT angiogram, CT abdomen angiogram, at the same time to see if there is mesenteric ischemia or a stroke, depending, of course, on the clinical findings of the patient. Okay? What about cancer? Cancer is a hypercoagulability state. So cancer by itself will give you elevated D dimer. But if you do fibrinogen is not. Okay? So again, repeating the factors that are present. What about if this patient is bleeding? If this patient is bleeding, what can I give to the patient? Can I give vitamin K? It's not wrong. Remember, your PT and INR is prolonged. So it's not wrong. Now, vitamin K only will target factor 2, 7, and 9, right? 11. But what about the rest of the factors? I can contain the rest of the factors by giving a patient FFP. Remember, if you give prior, it's only fibrinogen and factor 8. Now, what is the major factor that is depleted here? What is the major factor that is depleted here? Fibrinogen. So now if you have to select between vitamin K, FFP, and cryoprecipitate, which of the three you will select? Cryoprecipitate. So cryoprecipitate will be the #1 leader to give the patients with disseminated intravascular coagulation to contain bleeding because it's highly abundant in fibrinogen. Now you want to contribute with more factors because cryo is not containing the bleeding on the patient. It is not wrong that you can give FFP. It is not wrong that you can give platelets to the patient. It is not wrong that you can give also vitamin K. And you will see as well that you can even give desmopressine, you can give a bone growth factor for the patient as well. But the first leader initial treatment that contains high levels of fibrinogen, it will be cryoprecipitate. And it's the first treatment for this patient. Okay? What about heparin? Now, it's actually a controversy. It's a controversy.
Yeah.
Remember,
You can give heparin. Yeah.
I wouldn't get my
Remember, it's now, the only, let me tell you, the only contraindication for the use of heparin when the patient is in disseminated intravascular coagulation, because remember, even though you're treating the patient that is acutely bleeding with cryoprecipitate or FFP, platelets, or vitamin K, remember that their baseline, what initially triggered all these events is microvascular thrombosis. So the patient with disseminated intravascular coagulation is at risk of thrombosis. You can put the patient on heparin sub-Q prophylaxis. Give me 1 second, okay? What about if the patient already has a thrombi event? Patient's bleeding, but is having a DVT. The only contraindication for the use of heparin drip on this patient is when the platelets are less than 10,000. Exactly. That will stop the initial insult and therefore the vicious cycle.
Less than what?
Less than 10,000.
So then, you would.
Now, I will start with heparin sub-Q if the patient has no thrombosis whatsoever.
But if you already know there are conflicts and you
Another controversy, listen, another controversy is the use of platelets.
because they're already like overwhelmed.
Exactly. The reason why they're exhausted is because they're already migrating too much to the area, and they were actually elevated at the beginning, and then after that they were completely consumptive. Even if the patient is bleeding, if your platelets are greater than 10,000, do not transfuse platelets. So you would see this controversy if you read, for example, the Harrison or the new guideline. The new guideline says you never transfuse platelets on a patient that has disseminated intravascular coagulation unless the platelets are less than 10,000. And if you see that the patient has microthrombotic events Imagine the patient is in DSC and you see microvascular clotting on the toes. Or you do a venostop of the lower extremities and you see the patient has DVT or the patient has a PE. It doesn't matter that the patient is bleeding. You're going to give the patient cryoprecipitate, but you also have to put the patient on heparin. Unless, again, the platelets are less than 10,000.
The patient comes in through the ER, okay, they're like massively bleeding. Because obviously we're gonna know the labs, but by the time we wait for those labs, what are the first things that they can do? Platelets and maybe fluids.
Again, if you don't have no idea what the patient has, if you have no idea what the patient has, most commonly, the patients that come to the ER bleeding, massively bleeding, how will you contain the bleeding first? You don't have, you have to provide perfusion to the tissue. And the only way that you provide perfusion to the tissue is by giving packed blood cells and FFP. Because you're adding volume to that patient. So meanwhile, you have no idea what's going on to your patients. Don't give platelets yet because you don't know the laboratory result of the CBC. I understand that the bank is not going to approve packed blood cells if you don't know the hemoglobin level. But it's an emergency. The patient is this massive confusion because the patient is acutely bleeding. What would you request first? You request first. I understand that they give you a whole pool, so you need to have a judgment. And your judgment is to select first FFP and packed blood cells before you choose platelets or cryo. Why? Because you're giving the majority of the population factors with FFP and you're giving volume to the patient that most likely will be hypotensive. Right? Plus, you're giving blood. That even if the CBC comes back with a hemoglobin of 9, you know that 9 is not accurate. So that patient will need cells and volume. Cells produced by packed blood cells and volume and coagulation factors by FFP. I will select those two first. Then once you know exactly what the patient has, then you can select the platelets. Or
This is really what happens. If you don't come in that, they're bleeding. By the time we get the labs, we're already like,
what do we do most commonly, which is inappropriate? You can just treat. Okay? Any questions? I am so comfortable with this. we had a comfortable Okay. What other disease process can the patient come in and have an acute bleeding episode? Well, we already mentioned, what about if the patient has liver cirrhosis or hepatocellular carcinoma or hepatitis C, and the patient is now having portal hypertension? Okay? Or the patient has esophageal viruses, and the patient is having a massive hematemesis. What will you do first? And then you do to suction, right? You're going to intubate the patient to protect the airway. And meanwhile, GI comes on board. They won't be able to do an EGD with such a massive amount of bleeding coming out. So you could do a bleeding scan to see where it's coming from. Meanwhile, you have to contain that. Again, packed blood cells and everything. Okay?
Without even containing the bleeding, you're just replacing it.
Replacing it. Now, in the patient with liver cirrhosis or portal hypertension or esophageal viruses, what else can you give? Protonic strip, sandostatin to constrict the vessels that are bleeding. So basically what you're doing is vasoconstriction. Okay? And what else can you give in this particular patient? Vitamin K. But vitamin K doesn't act right away. Okay? It takes time. All right? Any question? This is mostly prevalent in pregnant women, but believe it or not, even though you're not a family nurse practitioner, I belong to the ICU and I run rapid responses. And we have to treat pregnant women in the first, second, or third trimester or after delivery when they develop HELLP syndrome. What is HELLP syndrome? Basically, HELLP syndrome is no more than an autoimmune response that is present on the pregnant women that is accelerated by preeclampsia. So basically, the patient is having, if you're not pregnant, you will never have HELLP syndrome. Okay? Males are accepted. So this is a pregnant woman that start having hypertension and proteinuria. Okay? And due to the hypertensive episode, there is an insult to the liver, producing inflammatory markers in the liver and elevating the liver enzymes. But once the hypertension has produced an engorgement to the liver and an insult to the liver, and the liver enzymes are elevated, the liver is unable to perfuse, because remember, 20% of the cardiac output goes to the liver and goes to the kidney, right? So if the liver is already damaged or insulted, secreting liver enzymes, in addition to that, the perfusion of the prerenal artery will also be compromised. And therefore, patients will start having leakage of proteins in the urine. So if you remember what preeclampsia is, if you ever have read that, it's no more than the combination of hypertension, more than 140/90, that has already affected the left ventricle and has affected the prerenal arteriole to the point of leakage of protein. Less than 2 grams, but still proteinuria. Okay? Now, in a patient that is pregnant, this preeclamptic episode has produced as well hepatocellular congestion and has produced ischemia, not to the point of necrosis, but inflammatory markers being released at the level of the liver. What's the major problem for this patient? Having fetal demise, having liver failure, renal failure, hypertensive emergency, and seizures. That's for the mother. But for the child as well, they can have neurotoxic episodes. And the patients not only can have a fetal demise, but the babies, the fetus, can also have neurological conditions at the time of birth. So it is your job, if you're ever called for a patient that is pregnant or close to the liver, that has a hypertensive emergency, you still have to treat those patients. So, even though the major risk factor is during the periods of 26 weeks to 32 weeks, patients can have it earlier in the first semester. Hopefully not, because the only treatment for this condition is the liver. Okay? The only cure for this condition is the liver. Because what has triggered this is an autoimmune response that the patients will start having hypertensive events and damage to the kidney and damage to the left ventricle. So if you don't take out the insult, the patient will not get better.
So once they have this condition, are they at increased risk with other pregnancies?
Yes, but in pregnancy only.
Yes.
Okay? That doesn't mean that the patient will become hypertensive after that. Okay?
So we did not.
But remember, once you have proteinuria, even if you deliver, that kidney is already damaged. Okay?
So how would you answer that call? Get called over there?
Normally we get called either for seizures or we get called for hypertensive emergency. The patient's blood pressure is 220 over 130.
My
Okay.
kids just treated.
On a pregnant woman, I will tell you right now how to treat it. In a pregnant woman or treating the patient that just had delivered. Okay? The first thing that you have to think, first condition that you have to think on a patient that is pregnant in any trimester, but most commonly the second and third trimester, or right after delivery, is not pain, is not a panic attack. You must rule out first HELLP syndrome by doing what? If I tell you that the triad is hemolysis, you're gonna do a CBC. You see that the patient has not only anemia, but low platelets, thrombocytopenia. Well, how else can you check hemolysis? Well, there's a substance that is attached to the red blood cell that when the red blood cells are lysing to really high extent, that substance gets depleted. If I have to attach to you and to all of you, and you start reproducing, what will be my saturation? My saturation will be really high, right? But my capacity to take more of you will be low. And that substance is called haptoglobin. So the haptoglobin being low is an indicator of hemolysis. So you would have anemia, thrombocytopenia, you would have low haptoglobin, and the AST will be elevated. What do you think? Which bilirubin will be affected? Direct or indirect?
Direct.
Why indirect? What was the first insult? Hypertension, left ventricular failure, then hepatic congestion. That's the cause for pre-liver, pre-hepatic. So indirect bilirubin with total will be affected, not mainly direct. Okay? So that is the major triad. Now, how will the patient present? Well, the patient presents with the signs and symptoms of hypertension. They have dizziness, they have headache, they have ringing of the ears. Sometimes, because the liver is compromised, one of the major symptoms that they complain about is abdominal pain, mostly in the right upper quadrant, associated with nausea and vomiting. Highly confused with appendicitis, and you say, appendicitis? Appendix is here. So when the uterus is so big, actually displaces the appendix. Not up to the level of the right upper quadrant, actually the mesogastric area, right? But it's highly confused with people think, oh, it has to be acute cholecystitis. And suddenly you realize that it's actually appendicitis because the appendix moves up in the third trimester of pregnancy.
How are they gonna diagnose that? They cannot do a CT.
They can do a CT, but you could do an abdominal ultrasound.
Yeah, but there's so much.
I know it's not highly reliable, but that's the only thing you can do in a pregnant woman, right? In the third trimester, you can do a CT.
Why they say that it's more common in really young pregnancies or older?
Well, the extreme of age is because first of all, actually, depending on how, okay, for the elderly, let's start with the elderly. For the elderly, it's because already the glomerular filtration rate is getting impaired, right? It's already declining. But in the young patient, the patients are non-compliant to the pregnancy, and they keep smoking and they keep drinking, and all of these factors are present. Of course, they're higher risk. If you're a very compliant person, you're not at risk of health syndrome with your mom. Okay? So, how do they present again? Even though with the most common signs and symptoms of hypertension, most of the time, described in clinical practice and the book, is abdominal pain, either epigastric or right upper quadrant pain, associated with nausea and vomiting. This pain is diffuse, it's constant. Sometimes located, as I said, in the epigastric, the right upper quadrant. It is not chronically, it is dull, okay? And when you do an abdominal ultrasound, you can find the etiology. It's not acute cholecystitis, it's not appendicitis, it's not an intestinal obstruction. Now you do a CBC, and you see anemia, you see thrombocytopenia, you see a blood pressure greater than 140 over 90, and you see elevation of AST. What you should do for this patient? Number one, control hypertension. How do you control hypertension? These patients, unfortunately, can only receive Hydroxyzine and nifedipine. Only two.
What about the two?
Don't need too much of a drop of blood pressure. You can create hypotensive episode, which is really bad for the fetus. They can receive it because it's a category A and B. They can, but it's not the first choice for these patients. Labetalol, hydralazine, and nifedipine. Okay? Now, what else do you need to give? These patients are high risk for seizures and the fetus for neurotoxicity. Magnesium. Magnesium sulfate as a drip. You start with 2 grams and you continue the drip. And what do you have to check? Muscle reflexes. You have to check the internal reflexes for this patient. But if I ask you, what is the most or the absolute treatment or the most relevant treatment for this patient, is delivery. Now, unfortunately, if the pregnant woman is less than 32 weeks of pregnancy, the lungs are not mature enough, right, for delivery. And these patients will receive, in addition to hydrocortisone, to be able to have more maturity and prompt delivery. Even if it's 27. The guideline says from 27 to 32 weeks of pregnancy, you must give hydrocortisone and 48 hours after program delivery. Would you tell these patients to deliver vaginally? No, that's such a big stress. So they have to have C-section. So deliver the baby, control the blood pressure as I told you. You could do also plasma exchange. When will you do plasma exchange? Less than 27 weeks of pregnancy. That's the only thing that you can do. You have to tell the mother the complications of their pregnancy if they already have gone through eclampsia, because what's the difference between preeclampsia and eclampsia? The seizures. So once the mother has a seizure, it's already eclamptic pregnancy, high risk for fetal demise, and again, neurological toxicity of the child. So you have to inform all that it's her decision to continue pregnancy or terminate. And if they decide to continue pregnancy, the only thing that you could do is give magnesium to the patient, of course, control in the hospital, and do plasma exchange. And control the blood pressure.
Are you saying that if you treat all of this promptly, the chances of the baby, if it makes it, is gonna have neurological problems?
If you do not treat it properly.
Okay.
Yeah.
You can't really still just-
And the more events of seizure, and the higher the proteinuria, and the higher the hypertension, it's gonna produce more damage to the fetus. And to the mother.
Probably wait a long time before they go to the hospital.
Of course. Okay, so we talked about that, the coalition cascade. Okay, now, what can interfere, and we know that as the nurse, what can interfere with values, the laboratory values? First, a technique, right? Because if you leave a tourniquet for a long time, you can alter potassium, right? But you can start having hemolysis as well in the tube and alter the values. So depending on actually the phlebotomy technician, the technique itself, or for example, as I said, how come a patient is 6.8 hemoglobin and after one transfusion it goes up to 9? That has to be an error in the laboratory. So you also have to have that in mind. And if you have a doubt that this patient clinical condition doesn't match the laboratory results, you must repeat before you treat.
One kind of that would be like only put into a rate of control.
1 to 2, no more than that. Otherwise, the patient was hemodiluted, or you took the blood sample from an IV that had a lot of fluid, not sure. But it's impossible that the hemoglobin will go 5 grams after 1 unit of red blood cell. Okay? So here, for your refreshment, I also put the mechanism of action of all the anticoagulants. Okay? So we have warfarin, which is a vitamin K antagonist, and remember vitamin K also is a cofactor necessary for the production of factor 2, 7, 9, and 10. And heparin, either sub-Q or IV, is an antithrombin 3 inhibitor, okay? And therefore, at the same time, it will activate, in this case, inhibit all the factors of the extrinsic cascade, and low molecular heparin, which is a derivative from heparin. Okay? Now, the new inventions, even though they're not new anymore, besides heparin and Lovenox and warfarin inhibitor, is your factor 10A inhibitors, either direct or indirect. You have fondaparinux extra, which is actually one of the first choices for heparin-induced thrombocytopenia, okay, that can be given to the patient PO. That is, well, IV is Refluran or Agatroban. If the patient has a thrombotic event that needs drips, okay? Otherwise, you could transition the patient or start the patient right away on an extra. In the past, the only two anticoagulants or thrombin inhibitors that we were able to use, in this case, they're not thrombin direct inhibitors. They are glycoprotein 2B3A inhibitors. Those are Agatroban and Refluran, okay? But now we can use therapeutic dosages of Alixtra from 5 milligrams to more for patients that have heparin-induced thrombocytopenia, okay? Very good also for patients that have renal failure. But the best anticoagulant to use for patients with renal failure would be heparin, okay? Another one that is out in the market but we don't use as much is Xantan, which still need FDA approval this last year. We also have Pradaxa, which is a direct thrombin inhibitor, highly used as well as Alixtra and Eliquis for patients that have orthopedic surgery. Okay, any patient that has a DVT or PE, or a patient that has orthopedic surgery, you could transition these patients after inhibiting heparin or Lovenox to Alixtra or Eliquis or Pradaxa. Xarelto, the problem with Xarelto, even though it's as well a factor 10A inhibitor, is that you need to have a creatinine clearance or GFR more than 30, because it's 80% clear by the kidney.
More than 20, you said?
Okay, so as a summary, before we take a break, as a summary for the bleeding disorders, if we go through the laboratory results, remember that the main factor that is elevated in hemophilia is your PTT, okay? The same as hemophilia A, B, and C. For vitamin K deficiency, the main factor that is elevated is BT and INR. For disseminated intravascular coagulation, the main factor that is decreased is fibrinogen. Heparin, remember that affects the extrinsic cascade, so therefore PTT, you know that already. And warfarin, the intrinsic cascade, so therefore PT and INR. And liver conditions, remember that patients that have liver conditions, the main factors that are affected besides vitamin K will be your vitamin, your PT and INR. So you can take a break and we'll start, I think it's 10 minutes after this. No, 3 minutes. Okay, how would that? 7 minutes, 10 minutes. One more. Alright, so let's start now with the platelets. Okay, so what can decrease platelet count? Well, first of all, if you have any type of major insult, for example, patient going into major septic episode and having aplastic anemia, or patients having chemotherapy or radiation therapy, antibodies, for example, patients having Ratuximab, which is a monoclonal antibody treatment that depletes the immune system, also depletes the bone marrow. So any major insult to the bone marrow can produce aplastic anemia, and not only the patient would have anemia, but they can also have thrombocytopenia, okay? What about splenic sequestration? Remember that I explained to you that every time there is a hemolytic event or a massive bleeding episode, that all the cells starts to crenate or break down, the major function of the kidney is to take those malformed, craniated hemolyte cells and eliminate them. When there's a massive amount of hemolysis, the spleen is working at a rapid rate and it goes into what's called sequestration. Sequestration is no more than a major engorgement of the spleen due to hyperfunction, trying to eliminate massive amount of any type of cell from the bone marrow that is going through hemolysis, okay? Or cells that are malformed, for example, in patients that have leukemias and lymphomas, okay? So when the spleen is working super fast, not only engorged, but it goes through ischemia and necrosis, that is called sequestration. And not only will eliminate the malformed cells, but it will start not recognizing immature cells, and the patients will have anemias and thrombocytopenias. Do you understand? Okay. So another type of disease process that can give you a thrombocytopenia is the dialysis. So every time a cell, including red blood cells and platelets, has to pass through a tube, through a narrow tube, can produce hemolysis. Uremia, highly toxic substances, ammonia elevated, urea elevated, and any type of toxic drum that you were studying with us in 669, for example, salicylic toxicity, patients with lead poisoning, patients with muscarinic agonists like pesticides. Patients can also have thrombocytopenia and anemias due to that. What we are going to concentrate today is immune thrombocytopenic purpura or thrombocytopenic thrombotic purpura, which are autoimmune conditions that could be triggered by infectious processes such as virus and bacteria, but can also be induced by autoimmune conditions such as hypothyroidism, lupus, and also cancer. Mostly cancers from the hematopoietic system. Other causes of thrombocytopenia could be drugs. As I mentioned, if you have a patient with any type of monoclonal antibody, methotrexate, for example, treatment for patients with rheumatoid arthritis or patients that have ulcerative colitis or Crohn's disease, that is an insult to the bone marrow, and the patients can have thrombocytopenia. Okay? Platelets can be degraded as well due to antiplatelet medications. So patients can have thrombocytopenia just by having aspirin or Plavix or Brilinta. Okay? Patients can also have thrombocytopenia due to an autoimmune reaction derived from antibiotics. For example, medications such as fluoroquinolones and aminoglycosides can induce thrombocytopenia. So I am telling you this to be able to try to recognize the factors that the patients are having and try to eliminate that rather than only give platelets to the patient as transfusion. Other factors that can induce thrombocytopenia, alcohol. So any toxic substance to the body can induce hemolysis of the red blood cells and the platelets as well. Diuretics, mostly hydrochlorothiazide, even though it's the first-line treatment for hypertension, hydrochlorothiazide can induce a lot of complications. Okay? ACE inhibitors and ARBs, how often do we give this to the patients? Being the first-line treatment for patients with CKD and diabetes, but as a complication, even though it's rare, can induce thrombocytopenia. I already told you about antibiotics. And of course, the condition that you have learned in pathophysiology, which is called hyperinduced thrombocytopenia. And we're going to start with that one.
The tissue one? No? The tissue one? The anti-convulsant?
Of course, phenytoin, dilantin, as well as tegretol can induce that. Lithium can induce that. So there are many, okay? So what is heparin-induced thrombocytopenia? Is, in essence, a hypersensitivity reaction type 2, if you remember what that is. is no more than autoantibodies that the patient creates or the immune system creates once the patient is exposed to heparin. Heparin being the antigen, the immune system recognizes this as a foreign body and starts to attack. So the major clinical condition that the patient goes through is by being naive, never been exposed to heparin in the past. So when the patient is exposed for the first time, in the first 5 to 14 days, the patients will start to develop antibodies against the platelet factor 4, okay, against the heparin. So we start forming autoantibodies, which are called platelet factor 4, which is no more than a tissue-specific antibody created against the platelets. That's the reason why it's in fact it's a hypersensitivity reaction type 2. Sometimes the patients can develop heparin-induced thrombocytopenia longer than 5 to 14 days. Rare, it's not even described in the literature, but I have gone through and read a lot of research studies about that sometimes the patients don't develop hypersensitivity reaction type 2 and they develop type 4. So basically T cell mediated, but anyways at the end it's the same result. So even though, as I said, the most common presentation by book is the patient being exposed to heparin, and by the 5th day that the patient has been exposed to heparin, up to the 14 days, the patients would have a depletion or decrease of platelet count by 50%. I have seen it in clinical practice earlier than 5 days. Why? Because this is not your first time. Remember that it's primary and secondary response of the immune system. As soon as you get exposed to the heparin again, the immune system recognizes it faster, has already created antibodies and start attacking the platelets sooner than 5 days. And we have also seen it after 15 days that the patient has been admitted already receiving heparin, and the patients suddenly start developing thrombolysis on heparin, either prophylactic or therapeutic dosages. And that's because some patients don't create antibody early on, and this is a late response, by the T cell mediated immunity. And that will be type 4.
Then, Professor, if the patient has the problem the first time, wouldn't they say something? They would know though, as a physician, then that they have this kind of a reaction, so that they don't give it to them.
Well, logically, if the patient starts having a depletion by 50% in the 5th to 14th day of life, after being exposed to heparin, you would have to report, so the patient has to be labeled as allergic to heparin, so they wouldn't receive the heparin any longer. But unfortunately, our communication, healthcare provider and patient, is so scant that sometimes the patients leave, they get discharged, and the patient has no information whatsoever, and they receive the heparin again on either the second admission or in another hospital, not even related. And so they have no access to the records, so they don't know. Okay? So there's basically a representation of patient received the heparin, and even though again this slide says 5 to 10 days, depending on the book that you read, 5 to 14 days, but again, your answer will be by the 5th, up to 14 days, but clinical practice, you know that there are very many variations. You can see it sooner, you can see it later. Basically, we'll start developing immune complexes, not immune complexes being deposited outside and then brought in into the nucleus, like type 3, actually attacks one tissue only. And that's the reason why it's type 2, and that can be a question for your board examination. They start developing IgG antibody against the platelet factor 4, necessary as well for clotting, producing the meshwork, not the fibrin, but platelet aggregation and clotting. Okay? Now, you might expect that if this autoimmune reaction will attack the platelet and would not allow the platelet to aggregate, the patient would have bleeding. But the problem is that there is a conglomerate amount of platelet being outside, waiting to be attached in the capillary that produces the clumping of platelets, and that's what produces thrombosis. So those platelets are floating, malfunctioning in the capillary, waiting for, even though there's no affected whole-bone factor or glycoprotein 2B3A, the platelet factor 4 necessary as well for aggregation is depression because it's been attacked by the immune system. And those amounts of conglomerations of platelets that are in malfunction, they can produce a clotting event or occlusive event. Okay? So the most common presentation for heparin-induced thrombocytopenia is not bleeding.
No, it's bleeding.
Most is not bleeding. Even though the patient is thrombocytopenic, the conglomeration of platelets being malfunction in the capillary will produce a veno-occlusive episode. Yes, but I'm talking about the actual pathophysiologic effect. Okay? So, the most common presentation for this patient is the following. You have a patient on heparin sub-Q or heparin drip. Imagine that a patient came in for chest pain, most likely troponins are elevated, right? You put the patient on heparin drip and the patient is waiting for cardiac cath. Or you have a patient with an ischemic stroke and the patient is on bed and the patient after having the CT brain, the MRI, the CT angiogram, there's no occlusion, patient is placed on sub-Q heparin, okay? To prevent prophylaxis. You expect that if a patient is getting heparin sub-Q or Lovenal sub-Q, because this could also happen with any low molecular heparin, right? That the patient is well protected against thrombi events, right? If it's given properly. Or if the patient has already a thrombi event, such as a myocardial infarction, or if you're treating a patient for pulmonary embolism, or if you're treating a patient for a DVT, and the patient is on heparin drip, and according to protocol, everything has gone successfully, you haven't dropped too much, the patient is well covered with heparin, you expect that these clots will be dissolved, right? Even though heparin will not dissolve the clot, the body will get rid of that because it's not a thrombolytic, you expect the patient to improve. How come if the patient is well covered, sub-Q prophylactic, now suddenly the patients develop a thrombi event? How come if the patient is being treated for a DVT with a heparin drip, or if the patient is being treated for a PE with a heparin drip, now suddenly the patient has another PE? Or right DVT and develops a left DVT on heparin drip? Impossible. The problem is that since heparin will be the antigen for this patient, the immune system is not recognizing heparin as a natural physiological, because we have it in our body, and starts to attack it. And that's the reason why the patient is well covered with heparin and patient continues to develop clots because the immune system is rejecting the heparin. So the most common presentation for heparin-induced thrombocytopenia is not bleeding. It's new formation of thrombi events or worsening of existing thrombi events. If at any point the DVT now gets enlarged, gets worsening, that could be a sign of heparin-induced thrombocytopenia. And what you have to do first is not a laboratory result, because you already have from the prior day, most likely, that the patients start dropping down by 50% platelet. First of all, as soon as you see that, your first initial step is to discontinue the heparin or low molecular heparin. Don't wait for the patient to develop a thrombotic event. Because again, patients will not bleed, even if they go to platelet count less than 50%. I'm sorry, less than 50,000. What they would do is thrombi. Okay? This is wrong, right, by itself. So if I ask you a question such as, which of the following assessment information will be consistent with heparin-induced thrombocytopenia, you're going to be looking for that thrombocytopenia. Or you're going to be looking for that 50% drop of platelet count by the 5th day. Okay? Now, what about if I have a patient on a DVT, left leg, on heparin drip, and I see that my baseline count of platelets was 180,000, and by the 5th day, now my patient has 60,000 of platelets. First of all, it's more than 50%. First of all, initial step is continuing heparin, but that patient is anticoagulant because it has a DVT already, right? So what will you put the patient on? You cannot put You cannot put the patient on any type of medications that will block the same indirect, because if you do indirect thrombin inhibitors, will also block antithrombin 3 and will do the same. So you can't do Pradaxa, you can't do Xarelto, okay? You have to start with the drip as well and bridge it to an extra. So agatroban as a drip or Refluden as a drip, which the classification for those two medications are glycoprotein 2B3A inhibitors. Refluden. Agatroban or Refluden. And as PO, once the patient is ready to be discharged, you can start the patient on an extra. Now, more and more I have seen in clinical practice, let me tell you what I actually see. I don't see starting our agatroban or Refluden, even though there's still many practitioners that does it like that, continue to do it like that. I see that they actually go straight and start an extra. 5 or more. So meaning 5, 7.5, because those are the therapeutic dosages for an extra. Do you understand? So the only 3 medications that can be substituting the action of heparin or low molecular heparin on a patient that has already had a reaction against the platelet by producing autoantibody against the platelet factor 4 in heparin-induced thrombocytopenia are Refluden, agatroban, or an extra. Only those 3. Okay? The rest can induce the same reaction. Now she says, what about giving the patient platelet? That's okay. That's okay. Let's analyze your question. What about giving the patient platelet? What do you do if you start giving the patient platelet? You're gonna clot more. So platelets are contraindicated. Platelets are contraindicated for the treatment of heparin-induced thrombocytopenia, unless the patient is actively bleeding, right? With a platelet count of less than 10,000. So laboratories, you know more than anybody that platelet factor 4 test is a sent out. It's not local in Florida. No, it's not. So it has to be sent out, and it takes days. Even if it takes 5 days, even if it takes less than that, are you going to wait for the platelet factor 4 result to stop the heparin? No. So you're going to do a CBC. You're going to see that the patient has thrombocytopenia. What qualifies is not having 150, 160, 55, 140. That is not heparin-induced thrombocytopenia. It's a major drop, okay, by the 5th day, more than 50%. Okay, so what else can you do? Well, you could actually check the platelet factor 4, as I said. You could check ELISA to see if the patient has IgG mediated against the platelet factor 4, because I'm not sure if you have seen in clinical practice that you suspect the patient having heparin-induced thrombocytopenia, but the drop of the platelet count, and you do a platelet factor 4, and the patient is negative. But if you have a high level of suspiciousness, you will never start the heparin or low molecular heparin. You will continue the patient with that extra, or reflutan or agatroban, and you could send a more specific test, which is called IgG by ELISA test. Okay? And many times that is possible. So, again, criteria. Thrombocytopenia more than 50% by the 5th day, even though in clinical practice we have seen it earlier. If the patient is certain anticoagulation because it has an MI, it has an ischemic stroke, the patient has a PE, a DVT, mesenteric ischemia, you're not going to leave the patient without anticoagulation. So what are the choices that you have? I cannot, and nobody can't put the 3 choices at once in the same exam. So agatroban, reflutan, or extra. Those are the only 3 that are acceptable. Okay? And here's your question. Should I administer the
No.
No.
No, you guys always attack me for that question.
Okay, so all the causes of thrombocytopenia. So what are the signs and symptoms of having thrombocytopenia and bleeding? Well, even though it's not a defect on coagulation factors, if you have now a mild trauma, you're going to develop ecchymosis, you're going to develop petechias, right? And purpuras. Patients can have gingival hemorrhages just by mild trauma of brushing their teeth or any type of dental procedure, gastrointestinal bleeding, large menstruations, menorrhagias, and even up to the point of intracranial bleeding, depending if it's mild or moderate to severe. Remember that the petechias are the red papules that don't blanch. Okay? So, the platelet disorders can be classified as quantitative disorder if you have a hemolytic condition. For example, if you have a patient with sickle cell disease, that would be a hemolytic condition, even though it's mediated by red blood cells. Okay? Or if you have decreased production, or if it's induced by any type of medication that can destroy that. In addition to that, it could be qualitative. So let's talk about having medications on board. I talked to you about uremia, if you have liver failure, and ammonia, if you have any type of toxic event, such as salicylate toxicity, Panathion, lead poisoning, that can also give you thrombocytopenia. If you have a patient that has gone the blood through a machine, balloon pump, a bypass, or hemodialysis, that can also create thrombocytopenia, despite the fact that uremia itself can give you thrombocytopenia as well. But what we're going to concentrate today is what factors affect the platelets aggregation. And we have, as I said, glycoprotein 2B, 3A, as well as bone growth factor. Okay? So, what is immune, the word is telling you, immune or idiopathic? What is idiopathic for you? Nobody knows the cause. So most likely is autoimmune. Okay? Thrombocytopenia purpura. So this patient, even though it's in your PowerPoint coming, most commonly is a middle-aged female. For some reason, even though it's not a congenital condition, it's acquired. The autoimmune condition that the patient is exposed to, either by viral or by bacteria or lupus or medications that the patients are taking or chemotherapy, patients developed low platelets. This has nothing to do with type 2 hypersensitivity reaction. This will be a late response. Most likely the patient 2 weeks before, a month before, had like flu-like symptoms, and then suddenly, 2 weeks, a month after, the patient started developing petechias or ecchymosis. Another example, patient hasn't been diagnosed of HIV, patient hasn't been diagnosed of hepatitis C, patient had a parvovirus, patient hasn't been diagnosed of lupus, or patient has cancer, such as lymphomas and leukemia, and now they start happening, unknown diagnosis, because malignancies can also induce idiopathic or autoimmune thrombocytopenic purpura. But the most common cause are viral diseases. And the patients will start having spontaneous petechias, purpuras, or ecchymosis. In this particular case, the patients will have a high risk for bleeding. We're going to go through one by one. Okay? Why? Because in idiopathic thrombocytopenic purpura, what the immune system will start attacking is not the platelet by itself, will be the bone membrane factor or the glycoprotein 2B3A. So those are the factors that allow platelets to aggregate. Okay? The platelets are not deficient in this patient. The patients have a normal platelet count, but the factors necessary for the platelets to work are deficient.
Which one are those ones?
Bone membrane factor or glycoprotein 2B3A. So that means that the platelets are worthless. They have no mechanism of action. And that's the reason why the patients bleed. Okay? Other factors that can give you thrombocytopenia, as I mentioned, are drug-induced. Another one that I want you to compare with is thrombotic thrombocytopenic purpura. What happens here is that, if you remember what I mentioned in coagulation cascade, I told you that when the clot is being formed through coagulation factors, you need natural anticoagulants to eliminate the excess of those fibrin formation products, right? Yes or no?
Yes.
Okay. The same thing happens with the platelets. We are a perfect body. We're the one in charge to mess it up, right? So platelets, when they start forming and aggregating, when there is an insult, we have another factor in our body that is in charge of not allowing the platelet to aggregate too much, to produce too much clot. And that factor is called Adams 13. Adam with a T at the end. Adams T13.
First time I heard of it. Item 13, yes.
Yes. Okay. So what happens in thrombotic thrombocytopenic purpura is that Adams 13 is deficient. And if Adams 13 is deficient, Adams 13 cannot eliminate the excess of platelet aggregation, and therefore more clot will be forming. Even though the excess of platelet will allow self-destruction. But what happened initially was a clot, a major clot. Okay, let me try to represent this on the board.
This one is this one. The immune and the whatever.
Okay, idiopathic or autoimmune thrombocytopenic purpura. The platelets are here, but they cannot aggregate to the endothelium because they're missing the factor that allows them to aggregate. So they're very, very dispersed, right? They can't attached to the endothelium to produce the clot. So if the patient has trauma, the patient will bleed. Because even though the platelet count is not affected, and I want you to remember that, what's affected are the factors that allow aggregation. That's Wolfram factor or glycoprotein 2B2A. In thrombotic thrombocytopenia purpura, this is the damage to the endothelium. The platelets will start aggregating to produce the clot, right? But they keep going and going and going because remember, we have a factor that is called Adams 13 that is reducing that, not allowing the excess of clot to form. So if I don't have Adams 13, I will keep clogging and clogging and clogging and clogging. It will never stop, but any excess as well by the immune system will say, this is inefficient, let me start breaking down by other ways, okay?
Like it gets tired.
That more, I mean, if I tell you, I'm gonna confuse you most, guanylate, cyclase, okay, and all factors that are starting, oh, this is too much, I'm gonna have thrombosis all over my body, right? Let me start to eliminate that, and that's the reason why, even though the patient is clogging and having thrombosis, the platelets are decreased by other means. Okay? So the major difference between idiopathic thrombocytopenic purpura and thrombotic thrombocytopenic purpura is what? Really? Thrombosis. Here the deficiency of bone growth factor and glycoprotein 2B3A. Here the deficiency of alpha 13.
No.
But the platelets are low here.
Yeah.
Yeah.
Because they still eliminate.
And the platelets are eliminated. But here the platelets are normal. What's abnormal is the factors that allow aggregation.
So how would you differentiate them?
Hold on a second.
CCP.
Laboratory.
On the-
I just introduced it. Now we'll go through the slides.
Okay, so the CCP, right? It's listing the Adam 13 and some of the other stuff that you talked about will come in and get rid of the excess. And those are the things you were talking about when you said like the leukemia factor and the factor 5, something. Okay.
But that's for coagulation. Nothing to do with the
So that's not platelets.
Okay. Okay.
That's what I'm
Going back, the reason why I mentioned you all the natural anticoagulants is for you to compare. For protein C, protein S, factor 5 lating, glucose anticoagulant, antithrombin 3 are your natural anticoagulants that go against the coagulation cascade, not the platelets. Even though the trigger factor for the coagulation cascade to be activated is platelet aggregation. Okay? Now, what goes against the excess formation of platelet aggregation is Adams 13. Okay? So, what do you think is von Willebrand disease? Well, von Willebrand disease is no more than an autoimmune condition that attacks the von Willebrand factor necessary for platelet aggregation. Okay? As you can see here, what is necessary for platelet aggregation? Not only von Willebrand factor, but also glycoprotein 2B3A. Otherwise, if those two factors are not present, or one factor is missing, the platelet aggregation will be impaired. Okay? In addition to that, if von Willebrand factor is deficient, von Willebrand factor is the precursor of factor 8. So that means that when a patient has von Willebrand factor deficiency, not only the platelets will not be able to aggregate and the patient will bleed, but the patients also will have factor 8 deficiency. That doesn't mean that the patient has hemophilia A. That means that indirectly, the patients will have deficient as well of factor VIII. Okay, so far so good? All right. So, as I said, could be congenital, most commonly is acquired, most commonly due to viral conditions, okay? But other disease processes that you must investigate could produce this. What are those? Hepatitis. So as soon as you receive a patient with bone warmer disease or ITP, what do you have to do? LFTs, hepatitis profile. What else? HIV, because HIV can trigger this. Cancer can trigger this, most likely, of course, from the hematopoietic system, so bone marrow biopsy or peripheral smear. Right? What else can induce this? Hypothyroidism. So TSH. So think about autoimmune conditions. Autoimmune condition, isn't diabetes an autoimmune condition? Isn't hypothyroidism, hyperthyroidism autoimmune? What about lupus? AMA. It's not me. When you read in your book, you're gonna realize that I'm talking the truth. Just like check everything. But yes, unfortunately, because it's called idiopathic and autoimmune, you need to check all the autoimmune conditions to see what is triggering this. Now, it makes sense that if the patient had a history of a viral disease 2 weeks ago, that would be it. So what will you do then? A viral serology. The most common virus, cytomegalovirus, Epstein-Barr virus, parvovirus. But that doesn't mean that the patient doesn't have HIV, or the patient doesn't have hepatitis B, right? Or C. Okay? So what will you see on the patient? Why does it say here that the PTT could be elevated, even though most commonly is normal? Isn't bone warmer factor a cofactor necessary for factor VIII? So if bone warmer factor is deficient, factor VIII will be deficient. And the only way that you can measure factor VIII is by doing the extrinsic cascade, PTT. Was it PTT the only factor that was deficient on hemophilia?
Yes.
So why not PTT being affected on patients that have ITP? Okay? So let's start with what is normal or abnormal. I do not want you to answer that the platelets are decreased in ITP just because the name says thrombocytopenic purpura. Remember that the platelet counts are normal. What is deficient are the factors necessary for aggregation and adhesion. Okay? So the platelets are normal. The PT is normal. The PTT most commonly is normal, even though it could be elevated due to the deficiency of bone warmer interfering with the production of factor VIII. So what's actually abnormal is the bleeding time. In reality, what we do is mostly an IgG and a peripheral smear to see the actual platelet morphology and amount count of the platelets rather than bleeding time. This is a very old-fashioned. Basically, you stick a needle on the patients and count. So we don't do that anymore, but unfortunately, we're tested on that. Okay? So what else would I be able to see? This is an autoimmune condition that, even though it's not destroying platelets, can induce hemolytic events, right? So no cystic, no anemia.
This slide is just about ITP, just like.
Yeah, bone warmer disease and idiopathic autoimmune thrombocytopenia is the same. Okay. So let's see what you would give to the patient. Do I give platelet to the patient? Platelets are not affected. So you can give me as many platelets as you want as transfusion is not going to work. What you have to give me is the factor that I have deficient. So you either give me the bone won't run factor, which is actually very expensive, like the same as factor 7. Okay, yeah, you actually requested super expensive. Okay, you either give me that, or what is necessary for the formation of factor 8? Bone worm run. What induces the formation of factor 8? Bone worm run. So why not give me factor 8 directly? Since they already have it deficient. So you can give me, let's start with the simple. So either give me the factor, give me factor 8, which is as well as expensive. The least expensive, which is mostly not for active bleeding, is for prevention. Imagine that a patient without immune idiopathic thrombocytopenia needs a minor surgical procedure. Not bleeding, the patient's not bleeding yet, needs a dental procedure, and you want to increase the bone wall run factor and glycoprotein 2B3A for them to adhere properly and not have an acute bleeding event during the dental procedure or during the mild surgical procedure. What would you give me? A medication that induces the formation of bone wall run factor, and that is desmopressin. Okay? Okay? What did I tell you about cryoprecipitate? What cryoprecipitate has? Factor 8, factor 13, and factor fibrinogen. Right? So, can you give me cryoprecipitate and load me on factor 8? So, that is less expensive than giving me factor 8 directly. So, cryo has factor 8. You can give me that if you're bleeding actively. You can give me factor 8 if you're actively bleeding. Okay? You can also give me bone wall run factor, but again, highly expensive, and it has to be request often, like it's not in every single hospital. So, or prophylactically, that's more fast. Congenital conditions that are super rare, that are cause of idiopathic thrombocytopenic purpura. Patients are born without or deficient of bone wall run and glycoprotein 2B3A. We already went through that. Same thing. Okay. Some books describe this as ITP. Some books describe this as bone wall run. The only difference, guys, is that bone wall run disease only has deficiency of bone wall run factor. And idiopathic thrombocytopenic purpura has deficiency of both glycoprotein 2B3A and bone wall run factor. But the same laboratory results, the same symptomatology, the same treatment. As you can see, as I told you, highly common in women, middle ages. So that means that I'm now 49. Viral, number 1 is viral. So if you have to choose a laboratory test after your hematopoietic CBC and bleeding time and PT and PTT, I would choose a serology for virus. I would do like a viral panel because that's the most common. And ask the patient if they have had any type of viral symptomatology, like flu-like symptoms. Okay? It could be present in pediatric and elderly as well, but it's less common. And the patients also could have, if this is congenital, of course, the patients could have history of menstrual disorders like heavy bleeding, or easy bleeding with any type of dental procedure. Now, to be able to assure diagnosis for any type of hematopoietic disorder, the simple one is to do a peripheral smear, basically getting a drop of blood and analyzing from the microscope, right? But the most specific diagnostic evaluation will be biopsy, right? For anything. How would you diagnose lymphoma? Biopsy. Bone marrow. How would you diagnose leukemias? Bone marrow biopsy. How would you diagnose ITPs and TDPs? Biopsy. How would you differentiate that I'm having thrombocytopenia induced by medication? Well, you can take out the medication and see the progression of improvement of platelets, but what can guarantee you differential diagnosis is having a bone marrow biopsy. Okay, remember please to rule out secondary causes of ITP, hepatitis, HIV, and autoimmune conditions. Okay? Now, it is an autoimmune condition. So what will you want to do as well, mentioning all the treatments that we have had already, the patient is prophylactically going to procedure, giving the DAZP, or actively treating the bleeding through cryoprecipitate or giving the factor 8. Remember, you need to deplete the immune system. You need to depress that immune system, and the only way to do that is by either giving monoclonal antibodies, which are very expensive, but you can start giving corticosteroids to the patient. Okay? So, in your board examination, the number one treatment for a patient with ITP will be prednisone. Okay? What else can you give? You can also give, again, monoclonal antibodies. You can give IgG. If the patient is getting cryoprecipitate and patients are not improving platelet count, platelet count is not affected, like bleeding time is not getting improved, you can also give what you give to the pregnant woman with a factor negative that basically attacks the red blood cells of the fetus. You can also give warhead to the patient to avoid the immune system attacking the whole factor of glycoprotein 238. Okay? But again, that is not the first line of treatment. Any questions? No? Now, going to comparison, which is thrombocytopenic, thrombotic purpura. Thrombotic, the word is telling you, so you can't miss that. What's happening here, even though the platelet counts are decreased, the patient is having thrombosis. Why? Because if you look here, what cleavages the excess of platelet aggregation naturally in our body is Adam's 13. If you congenitally or acquire by the same ecological factors of ITP is deficient, the clotting will not stop. Even though other factors by the immune system will start attacking the platelets and eliminating the platelets. Because otherwise you're gonna have strokes, MI, PEs, DVTs on the same patient. Right? So there's an attack or destruction of platelets, but after the excess of platelet has been formed, because either congenitally or acquired, the patient is unable to produce what cleavages the excess of platelet, which is Adam 13. Okay? So the key word is the widespread of thrombosis that these patients will have. Okay? So basically, the thrombi will be deposited anywhere in the body. If it happens at the level of the intestine, the patients will have mesenteric skin and thrombosis, right? If it happens in the brain, ischemic stroke. If it happens in the lung, pulmonary embolism. If it happens at the level of the renal artery thrombosis. So it can happen anywhere in the body, as you can see. Now, the leading treatment for thrombotic thrombocytopenic purpura is plasma exchange. How can you get rid of the excess of those thrombocytes? Dialysis, no, because you're not accumulating any type of toxin. You're accumulating clots.
How are you gonna actually change?
The same process of dialysis, but you're not eliminating solutes.
It's just like clearance.
Clearance only. Okay? Do you understand? So, plasma exchange, or the same way as plasmapheresis. When you have an accumulated, listen to me, the same you will hear in leukemias and lymphomas. When you have an excess accumulation of cells of the hematopoietic system, either immature, such as blast, or deficient, such as in this case, because there's factor that we're not allowed the elimination of. Yes, it will produce a thrombosis, okay? But the only way to get rid of that is to exchange the blood, okay? Otherwise, the patient will have more and more thrombotic events.
Would this be one of the reasons why I think I'm like kidney failure?
Yes, because they tend to have renal artery stenosis.
So they have plasmapheresis, so they can, in addition to sometimes CPVHD if they're in the ICU.
Yeah, I mean,
They
of
do it
course, at the
at
end, if the clot happens at the level of the renal artery and they have renal artery thrombosis and acute tubal necrosis and they have renal failure, they need to have dialysis. But that's later on. What they need to have to prevent renal damage is plasma exchange or plasmapheresis. Okay? YFP.
The plate, no, not the plate. That's fine.
But the measure is fine.
You're gonna dilute the
What do you think happens if the patient, what do you think happens, guy? Which of course is never ever the most common result of this condition. What do you think happens if I activate platelets and I activate platelets?
You run out.
Wouldn't I activate tissue factor?
Yeah.
Wouldn't I activate the entire population cascade? These patients, as a major complication, will go into DIC. And then they might need that. But not, it's never ever the first line of treatment. So don't tell me, Professor, in your slide 62, you have FFP.
So that's only one patient is perceived that they're getting to DIC state based.
What is the first line treatment for ITP? Steroids. What is the first line treatment for TTP? Plasmapheresis or exchange. Okay? So as you can see here, please check for hematopoietic cancers, infections, autoimmune disease, as I mentioned, diabetes, thyroid, lupus, rheumatoid arthritis, HIV, hepatitis C, highly common on these patients.
That's what I saw last week, that somebody came and did that, the patient was myasthenia gravis.
Why is that? Okay. Myasthenia gravis is also an autoimmune condition, right? That the patients, what do they have? Acetylcholine deficiency, right? Basically, the target organ here is the synapses of the neuron.
So when they do that, they do
The plasmapheresis, you mean? Yeah. What they basically are doing is removing excess of antibodies, okay, against the acetylcholine. But one of the main, that's for the patient's myasthenia crisis. But otherwise, the patient gets mestinol, which is an acetylcholinesterase inhibitor. Okay? What else can you get? Well, remember, these are autoimmune conditions. Besides plasmapheresis, you can also give patients recombinant for interleukin, which is a mediator of inflammatory response. So you will deplete the inflammatory response, and you can give that when you do that. Another one is the stimulator alpha factors, okay, for platelets. So you can give the patient platelets. Super expensive as well. They deplete the immune system, highly complications for infection. All right. So basically, again, you have a patient with a platelet count of less than 100,000. Your major suspicion is S. Infection. If the patient is infected, it makes sense that the platelets will drop, right? The patient is in renal failure, patient is having uremia, well, that's the cause. Try to eliminate that by either putting the patient on dialysis, which is an indication for dialysis uremia itself, okay? What else could it be? Do I have any type of hematological cancer that I can rule out? Bone marrow biopsy, okay? What about my platelet count? If the platelet count is normal, could it be ITP? Let me check my bleeding time. I know that we don't do that, but unfortunately by test you have to. my PT, my PTT, most likely are normal, right? So what else could it be? What else can give you thrombocytopenia? What about parasites? Any elevation of your eosinophils are also toxic for the red blood cells as well as platelets. So, for example, the patient comes from a third world country. I just came from Cuba last week. I didn't drink any of the water. But if I would have, maybe if I developed thrombocytopenia, you would have think about type of helmet or parasites. Okay? What about having thrombocytopenia due to heparin-induced? Was the patient exposed to heparin for the past week? Those are the questions that you have to ask yourself to be able to rule out heparin-induced thrombocytopenia. If for the country, I have low platelets, but in addition to that, I have PT, PTT, elevated INR prolonged as well, and I have fibrinogen low and D-dimer elevated, your suspicious will be DIC. And that's exactly what I'm going to do here. What about having checking the factor Adams 13? The patient is not bleeding even though the platelets are low. When the patients are thrown by, let me tell you as a summary. When the patients are having thrombotic events, from this lecture, it could be only two possibilities. You either have heparin-induced thrombocytopenia and you must have that as a history, or you have TIC. Or TIC. So how, from the thrombotic events, you have three possibilities. How are you ruling out heparin-induced thrombocytopenia? I have to give you in the paragraph or in clinical presentation the history that the patient was covered by heparin or Lovenox. The patient was not covered by heparin and Lovenox, rule out. Okay? Yes or no? Yes. Good. In addition to that, let's imagine the patient has been on heparin and Lovenox. What factors are you looking for in heparin-induced thrombocytopenia? What about PT? What about PTT? Are they prolonged?
Yes.
No.
Heparin-induced
Sorry.
What is the main factor that is affected? Drop of platelet by 50% on the 5th day.
That's the rest.
So platelets count are decreased, but they do not have PT, PDT, INR, or fibrinogen affected, right? So my second possibility is TTP, right? So if I have TTP, unfortunately, what I have depleted only is platelet, but the patient is having thrombotic event. Then my chances are only to check Adam 13. And the only other conditions, so three conditions, HIT, TTP, and DIC for thrombosis. So in DIC, I will have low platelets as well, but the patient will have PT prolonged, PTT prolonged, INR increased, low platelets, low fibrinogen, and high D-dimer. Okay? The rest, I believe, is just transfusion. So, as I told you before, by 1 unit, remember that you asked me this question? By 1 unit of platelet, 1 donor, 10,000. You can store up to 5 days. I'm not going to ask you any of that. Okay? So remember that even though some books tell you don't transfuse platelets unless you have 10 to 20,000, the new guideline says that you only transfuse platelets if the patient is actively bleeding and the platelet count is less than 10,000. Let me see what else. Oh my God, it's already 8 o'clock. One second. So these are the complications of hematuria. So let's analyze the laboratories again. In the CBC, this is basically just for you to know laboratory. Okay? Nothing to do with diseases, but the CBC, what are you looking for? Your hemoglobin, your hematocrit, your RBC, your RB width, is your MCD, your MCHD, right? That's for anemia. In the coagulation, we're looking for the PT, PTT, fibrinogen, INR, right? And the thrombin time. For platelets, we're going to be looking for the bleeding time. You can check whole bone run factor. You can also do the amount of count of platelets and the actual functional morphology by peripheral smear. And analyzing the disease process that we already went through, what about having TTP? How are the platelets affected in TTP? Okay. How are the platelets affected in ITP? Normal. Okay. DIC. How are the platelets affected in DIC? They're low. Okay. Coagulation. PT, PTT, and INR are affected in DIC. Right? D-dimer is elevated in DIC. Fibrinogen is low in DIC. Going to hemophilia. PTT is the only one affected in hemophilia. Liver diseases. PT and INR only. Right? Bone-bone factor. Even though in bone-bone factor, the bone-bone factor is the only one that is affecting bleeding time, since bone-bone factor is necessary for factor VIII formation, even though the PTT most likely is normal, sometimes is elevated because factor VIII is deficient as well. Okay?
And the INR, right?
We covered the INR.
The one William Bryan
Bone-bone factor, but
that has the high INR.
no, because factor VIII is extrinsic, not intrinsic. So it's PTT only, no PT or INR. This is, again, going over the therapy. What do we have in FFP? Every single coagulation factor except platelets. Oops. Cryoprecipitate, factor VIII, fibrinogen, and 13. So when do I use FFP? Bleeding through any cause except thrombocytopenia. And you want to give volume as well. Cryoprecipitate when you're missing factor VIII, so in hemophilia, A, right? In bone-bone factor, you can give it too because it's deficient, and in DIC because fibrinogen is present here and it's deficient, right? Amicar, which is aminocaproic acid, the same as DDAVP. DDAVP is to enhance the production of bone-bone factor. Amicar, or epsilon aminocaproic acid, enhances the formation of factor 2, 7, 9, and 10. Okay, so it helps, for example, in patients that have hemophilia B or hemophilia C. DDAVP, remember DDAVP? You give us prophylaxis when the patients have bone-bone disease. For those patients that want to have a surgical procedure, I'm not saying that you're not going to take the patient to surgical procedure having bone-bone disease only with a shot of DDAVP. I know for sure you're not going to do that in clinical practice. That you have with you what? Your cryo, right? And your pyramidal cells waiting. But unfortunately, on exam, this patient is not bleeding, so you only do prophylaxis. And factor 7, you can also give it as last resource for patients that have DIC. So you can read all that since we already have gone through it one by one. platelets. This is mechanism of action, okay, in case you don't remember. You can read it on your own. What is aspirin? Inhibition of prostaglandin and the arachidonic acid pathway inhibiting cyclooxygenase, right? Plavix. The major mechanism of action of Plavix is also inhibiting protein aggregation, but it's not mediated by cyclooxygenase or prostaglandin. It's mediated by inhibiting ADP formation. Therefore, glycoprotein 2B and 3A would not form. Okay? Persantin is no more than this is a vasodilatory response inhibiting phosphodiesterase and glycoprotein 2B 3A inhibitors. Remember that you need two factors necessary for protein aggregation: gold 1' and glycoprotein 2B 3A. So, if I inhibit glycoprotein 2B 3A, platelets will not aggregate, and these are the medications that you can give in patients, for example, that have HIT, like Atrovan, Durafluta, Integralin, okay? And Agranox, which is a combination of dipyridamole, which is a vasodilator with aspirin. That's your pathway, and where do they act based on the mechanism of action. So this is a female status quo spinal patient mobile biopsy 2 days ago. She comes into the ER complaining of increased bleeding at the incision site. She has not been able to control it. Laboratory results show hemoglobin of 10. Hematocrit is 28.9. Platelets are 350, no 1,000, 350. MCV is low. So far, if you remember anemia, I have anemia with a low MCV and a low MCHC, so I have an iron deficiency anemia. Normal PT, normal PTT and INR, and bleeding time is elevated. What do I have?
ITP.
You're in the blue moon. ITP. Yes. Why? Because bleeding time is elevated. PT is normal. INR is normal. PTT is normal.
But the platelets
Vitamin K is PT and INR, intrinsic cascade. You learn anything with me today? 18-year-old college student with no pathway medical history presents to the ER with a huge rash. She also described having a headache, fever, arthralgias for 3 days. On examination, temperatures 101.2, BP alert person, nuclear rigidity, photophobia, so she has meningitis. Her gums are oozy, abdomen is soft, non-tender, petechial rash. You're concerned about meningococcemia. You start the patient on Rocephin and Bancho, even though that has changed already a little bit. 13,000. Platelets 80. PTT is prolonged. INR is prolonged. Fibrinogen is low. I'm going to give you the normal values. Okay? So don't panic. I'm going to give you parentheses the normal values. So what do I have? DIC. That was easy.
Yeah.
You just look for the fibrinogen. So how will you treat this patient?
Right.
Will you give IV heparin? Will you transfuse cryoprecipitate vacuum? Pack red blood cells, platelets, or FFP? Okay. Let me look at the hemoglobin. What's your hemoglobin? Then,
And what are all the platelets? The batteries, right?
what did I say about the platelet? Patient in PIC is going through thrombosis. These are older conditions that can trigger thrombocytopenia, as I told you, bacterial infection. Uremic syndrome can also give you thrombocytopenia. This is what give me a second. Remember that I told you that we have natural anticoagulants in our body, that the main function is to get rid of the excess of clotting, right? Those are factor V lady, you have a reason there, protein C, protein S, glucose anticoagulant, factor V lady, anti-thrombin 3. What about if congenitally you're born deficient of those anticoagulants? This is the presentation of a patient, very young patient, that has no risk factor based on the virtual triad that you have learned before, right? Immobility. Have you been traveling outside the country for many hours in a car or in an airplane? Recently, it's less than 1. What about being on bed? Any type of immobility caused by, I don't know, the patient had a trauma and had to be in bed. Okay? Any major fractures, any major surgery that produces endothelial injury, right? What about hypercoagulability conditions, such as cancer? This is a young patient that you're looking for risk factors and you can't find them. And if you ask, because if you don't ask, it will not come out. Most likely, the primary degree family history have had thrombotic events before. That means that this patient most likely has an inherited condition deficient of the natural anticoagulants. And this is just a simple blood test that you can run. And if this patient is deficient of any of these factors of anticoagulant, these patients are at high risk of thrombotic events for the rest of their life. And they must be an anticoagulated for the rest of their life. Otherwise, they're high risk for stroke, PEs, DVTs, and MIs. Okay? So basically, what laboratory test are you going to run? The same laboratory as your natural anticoagulants. It's called hypercoagulability panel. Okay? And that's it. Thank you for staying until the end.
Thank you.
Now, because I talked too much, I didn't have the time to cover anemias. Please listen to the video, come prepared, and I will ask you questions about anemia to the point that you will master the content before I start answering. Okay?